Perfect. Got an adapter, I think you said you needed, and then we've got a clicker here as well. Just oh, right, I don't have this isn't selected right now.
Oh,
Let's see. So I have you unmuted so people who Zoom can hear. I'll hide that. Minimize this.
okay, no, it's working again.
Everything is working. And then do you want this on?
Sure.
The mic? Okay.
Yeah, sure.
What do you mic should be on now. Right.
Thank
You're
you.
good to go. We'll stick around for the first like
Okay.
10 minutes.
刚看到你的 message。哦，还行，因为现在都在这个 Mac 上，我感觉好像是被你的任务优化跟我上次没有对比到。对，因为每次或者都要重新定，我还认为自己上一次的用。啊，还会这样，所以你们不能一年都定下来这样。对啊，因为就算是一个课，然后还教学，对，我就说，我感觉好像以前就是往上走一点就到了。对，我感觉今天哎怎么走了半天还到了？Yeah, I'm gonna start playing Jasper's.
Oh yeah, it's just loud. Shit, I don't You already told me, but I don't think I need to get to it. And remember to put other. She said she might be late.
See, good to see you.
I have to run at 4:30, like immediately after the first
Sure.
meeting, but hopefully you don't mind.
Oh, sure. I have to,
Are you?
happy. Just feel like when you get older. Stuff that you have to take care of. Not, I mean, just for, but
Oh,
not
okay.
really. Like so many.
Oh, no.
Chaos.
Oh, no. Oh, I feel
I'm just saying.
I already feel like it's too much. I procrastinated, so I got yelled at. No, I'm exaggerating, but our pre-award person exaggeratively yelled at me because I started my budget too late. It's for the R35 view in 2 weeks, but one of the people doing the validation is at Fred Hutch. So it needs to go through the Fred Hutch system, and I'm just like, oh crap, I definitely procrastinated on this too much. And so I'm just like, I don't know. I still don't know if I actually am gonna have the, so yeah.
Are you waiting for them? So are you
We,
awarded or are you like waiting for the results or are you submitting?
oh, submitting.
Submitting, okay.
And the budget phase is, we haven't even formalized what the Fred Hutch subcontract would be. So I'm hoping that part will take too many days, because yeah, I mean,
Yeah,
there's
I know.
a non-zero chance
so
that I'm gonna miss the
that's
deadline.
part of non-research thing, right?
Staring at budget and stuff. Ah,
Okay. We are putting too many. Yeah, but I can see the and touch of the research. British decisions. I feel that is my, no, I think so. Oh, okay.
She's the only one.
yeah, like,
I'm also asking something for her. And going to ask me, so I imagine she's like
yeah,
exploding.
not happy that I procrastinated. But it was the same, because I also realized that.
Yeah, that Victoria has a lot of paperwork. Exploding, you know?
I think if Cynthia ever left the department, would immediately. Like, in terms of like who's the most important person, is probably her. Like,
Having a thing is definitely.
no, it really is.
Yeah, but then.
So hope your research goes well.
Nothing else going on like right now. So only that, so I think so, because I'm not even aware of what else. Is like the whole house could be on fire, but I'm just only focusing on this part of it. I'm doing all right. There's one.
Yeah. Yeah, I'll manage the Zoom, so you don't
Okay.
have to worry about Zoom.
So you'll monitor the chat.
Yeah, usually there's no question from. Hi, everyone. Welcome to the second seminar of the quarter. Today, we're very happy to have Dr. Yingqi Zhao presenting her recent work today. And Dr. Yingqi Zhao is professor in Public Health Sciences Division at the Fred Hutch. And her work focuses on developing novel statistical and machine learning methods for personalized medicine, dynamic treatment regimes, disease screening and surveillance, clinical trial design, and electronic health records. And Dr. Zhao collaborates with Fred Hutch-based Statistics and Data Management Center for the SWOG Cancer Research Network and Early Detection Research Network. Today, Dr. Zhao will talk to us recent works on cancer early detection and therapeutic studies. We're looking forward to it. Thanks.
Thanks, Ting, for the invitation and for the nice introduction. And I'm very glad to be here and present our recent work on this is like a combination of our recent work on both cancer early detection and therapeutic studies, which compose a big chunk of my research portfolio. So basically, I'll cover two topics. The first one is on this cancer randomized screening trials. I think most of you might be more familiar with randomized therapeutic trials, and today I'll be introducing the screening trials and the challenges in designing such trials. And the second topic is on the kind of combination of clinical trials and real world data. So how can we better leverage the real world data in trial-related questions. So first, for cancer screening, I don't know if anyone is aware of screening measures. I believe so, because like mammo for women, right? And there are a lot of screening measures recommended for adults older than certain age. And how did those recommendations came out? It, of course, come out with the rigorous studies, the recommending those measures. And for those, we will need such cancer screening trials. And the challenges for such trials is that we are looking at healthy participants. We're looking at healthy population. And you're waiting to see the results. You're waiting to see whether they will benefit from such screening to reduce mortality, right? Like from healthy population, and you want to see mortality or at least cancer incidence events. And that could take a long time. So for such screening test, there were a lot of questions that, of course, of interest. And the most important is, of course, the benefit of such test. Will this screening test change the cancer-specific mortality, right? That would be the kind of gold standard question. If this screening test, when you apply this to the whole population, it will reduce the cancer-specific mortality, that will be the gold standard. And there were another question that also related. Will the screening test change the distribution of cancer stages? What does that mean? So for example, if you don't have any screening test, you're just waiting for the disease to manifest themselves. So when that happens, it might already be late stage. But when you implement this screening test, it might identify the underlying disease earlier. So when such disease is identified, it could be in an early stage. So if we can kind of do shift the stage from late to early, that could be also beneficial. So that's another question, that's Q1A. And such benefit in stage shift, of course, usually will proceed before the benefit in mortality. So that's more like a short-term surrogates for the long-term mortality endpoints. And the second question is the accuracy of the screening test sufficient for potential implementation on the population? Such screening test property includes sensitivity, specificity, and so those high enough to introduce into the population. If you have very low specificity, right? So of course you will introduce many harms, introduce a lot of false positives, and also if you have very low sensitivity, you're not good enough to identify cancers. So what kind of bar are required, right? Like how high a sensitivity or how high a specificity should be in order to be implemented or even to be considered as a candidate in the trial. And the third are the harms associated with the screening and its follow-up procedures. And as I mentioned, the harms could be false positives. So you don't have cancer, but the test said, oh, you have cancer. And you have to go through all the follow-up measures, and you may psychologically might be very nervous, right? So those are harms. And also there are overdiagnosis that you might, if such cancer is not found, you may just live with it, and you may not know about this at all. But once you have done this test and you have found, oh, I have cancer, and then that's also another potential harm, because you could have just lived with it. yeah, so all these questions are very important, and especially with the recent development in multi-cancer early detection test. So that's basically a blood test that measure you and tell you if you have elevated risks for a basket of cancers. So we can imagine for those, you have to get very high specificity, right? And there were many companies that are currently doing such tests and trying to make it commercial, trying to commercialize the product. And so basically, if you're willing to pay, you could just do this test, right? Like how much you're willing to pay such a test to see whether you have elevated risk of all those cancers. So that's also part of the benefit cost, right? So for my talk, I'll mainly discuss this first question in the benefit in terms of the distribution of changing the distribution of cancer stages. And again, the challenges are typically such trials are of huge sizes because we are looking at very low event rate. And to reduce the sample size and trial duration, and instead of mortality, there have been kind of advocacy for some short-term surrogate endpoints, such as the late-stage cancer incidence. And because this endpoint does not suffer from overdiagnosis, so usually it's a more preferred endpoint. If we're looking at for example, the cancer incidence, you're incorporating those early cancer incidents, and that could be overdiagnosed. And the goal of this project is to provide a method to design such a trial with late-stage cancer incidence at the primary endpoint. And this is a joint work with Zhao and Yingqi, and Zhao is a recent graduate from the department. And again, let's go back to the therapeutic trial. If you are designing a therapeutic trial, you need to know the effect size of the intervention, right? And the typical practice is to run a smaller trial, a phase 2. And you from this smaller trial, you hypothesize the effect size for a larger trial. But in this case, it doesn't make sense to run a smaller trial because the issue is you always need to wait for a long time to get the effect size. So it's not like the therapeutic trial that you can run a preliminary smaller trial to extract such effect size. The information you know would include the test properties, sensitivity, specificity of the test, right? And disease progression property, like how fast the disease progress, and et cetera. So that's the information we have. And for our project, we're using those information, trying to calculate the project effect size. And with that projected effect size, we can design the trial accordingly, including how many, the sample size, right? How many people we need, and how should we administer the tests? Like, should we do annually? Should we do biannually? And how many tests we should do in the trial? So all those trial-related properties. So here is a diagram on how the schema of a screening trial. In the control arm is whatever is currently adopted. And in the experimental arm, we have this new test that could be screened multiple times, right? From S1 to SN. And we can look at the late-stage cancer incidence reduction as the endpoint. And ideally, we also, of course, want to look at the mortality reduction, but that's not in this the focus of this paper. And the hypothesis is that the null hypothesis is using these new screening measures, you are not improving the late-stage cancer incidence, right? So, this we're looking at this basically the cumulative probability of late-stage cancer in both arms. And the question is how to specify the effect size. And there were many, there are methods like for designing the screening trials that use the mortality endpoints. And that paper in Hu and Zelen, they use this classic model, has 3 states. Basically, you're considering these progressing states from normal state to preclinical state, and the clinical state when they become symptomatic. And preclinical is that when you it's not symptomatic, that can only be tested using some screening measures. And for such classic models, they can be used to infer the effect size in mortality, but they cannot look at this reduction in cancer late stage incidence because they don't distinguish early stage from late stage in their model. So what we do is we leverage this expanded model, the 5-state model, that basically we look at normal state. Normal state can progress to early preclinical state. And from here, it can either go to early clinical state that the symptom manifest at the early stage, or it can go into late preclinical and then to late clinical state. So we have this 5-state, and using this 5-state model, we can, because it distinguish early from late stage, we can try to infer the, project the reduction in late stage cancer instance. And we need several types of parameters. The first one is the parameter related to screening program. So that's the early sensitivity and late stage sensitivity. So which means how good these screening tests are in detecting cancers at early preclinical and at late preclinical, so respectively. And such parameters can be obtained from earlier phases of biomarker studies that's usually like kind of like phase 3 screening trial that will phase 2 and phase 3 will give us such information. And again, as I mentioned, we also look at frequency and timing of repeated tests. That's also part of the study design. And the second set of parameters are on natural history. So this is related to the disease characteristics. Like lung cancer might be different from pancreatic cancer, right? How fast it progressed and how long it'll stay in a particular state. So this will vary across different diseases. And for such natural history parameters, we will need the incidence rate of early stage preclinical cancer and time spent in each state, how long it'll stay, like say in early preclinical, say in late preclinical. And such time, the time spent in each state, usually is characterized by these mean surgeon times. And we assume this stable disease condition. And that basically means the disease progression is kind of in a constant rate. And using this stable disease condition, we can calculate this rate. Essentially, that can be computed using the prevalence and the incidence. It might be helpful to look at this prevalence pool example. So this pool of water, you can consider it as the prevalence, how many subjects having the disease, how full, and the inflow. So there is an inflow, like water getting in and water getting out. stable disease condition basically means the speed of getting in is the speed is the same as the speed of getting out. So that means a stable disease condition. And so with the incidence, like how fast it gets in, and then with that stable disease condition, we can calculate basically this rate. Yeah. And then with all those set of parameters, we compute the probability of late-stage cancers detected by screening test, and also the interval cancer, that's the natural clinically diagnosed cancer. So this, again, is some derivations. For example, this screening detected, we are characterizing all the possible paths to this outcome. For example, if you are screen detected in this interval, the chance is that you are having cancer in this interval and you are detected, right? Or you actually have cancer before you're entering sometime, but you are not detected by the test. So that's a false negative. So we're characterizing all those possibilities and basically just write down and calculate such probability and then aggregate all of them together. And that's the key, kind of the key part of our work. And once we have this theta t derived, we can design the study because now we have the projected effect size. So with our proposed method, we try to redesign the NLST, the National Non-Screening Trials. So it was a successful landmark trial that randomized eligible smokers to chest radiography arm and the low-dose CT, the experimental arm. And now the low-dose CT is actually recommended for smokers. And the Huan-Zelen model was used to design the trial using mortality endpoints. The total sample size is 50,000. And we redesigned this trial using late-stage cancer incidence as the endpoint and using the same set of parameters assumed in their design paper, and with some, and also some additional inputs for late stage and early stage cancer, because for their work, they don't need to distinguish stages. And for our case, we consider 3 annual tests. And of course, we also look at multiple set of tests, but here is just an example that we look at 3 annual tests, which was done in the trial as well. And if we're looking at 40,000 at year 6 or 50,000 at year 4.2, that's earlier than year 6. So we could detect we could detect this reduction in late stage cancer incidence 20%. That's what's observed in the trial. So yeah, that's what I want to discuss for this particular paper. And it might be, the terminology might be kind of different from the typical therapeutic trials. But I think our method is promising in the sense that we introduce this late stage cancer instance at the endpoint, and that could be used for our further development when we want to generalize to mortality, that we can connect these surrogate endpoints to mortality in the design phase and try to learn more about what's going on and whether and whether the reduction in late-stage cancer incidence could inform the reduction in mortality. So trying to use such model to connect different endpoints, I think would be very beneficial. And as I said, like here, this is the extension we're working on. We are trying to extend to incorporate the mortality endpoint. And this will incorporate like what's happening after cancer is diagnosed. And we can imagine this will depend on the follow-up therapeutic measures, right? Like how good is the current practice in treating those patients, how good they are in treating late-stage patients, and how good they are in treating early-stage patients. And those will be reflected in our model. And we're trying to use this expanded model to explain some of the phenomena we see in practice. And finally, we are also interested to look at the harms associated with the screening and the performance bar required for certain tests. And those need to require some understanding of stage-specific biomarker performance, like sensitivity, not only sensitivity, but now here we want to look at specificity, so look at false positives and how they interplay with natural history. Okay, yes.
So just thinking about this endpoint of late stage cancer incidence, like I feel like the context of the cancer and how it's treated, like is potentially really important in thinking about whether that's a good idea. Like I think about like very hypothetically, but like a breast cancer, it could maybe encourage a lot of overdiagnosis of early stage cancers because you know, if early stage breast cancer is diagnosed, some subset of those women may just really get terrified and, you know, go for a double mastectomy. And, you know, some of those might be preventing late stage cancer, but a lot of those maybe would be unnecessary if it was overdiagnosis. So like in that particular example, that endpoint worries me a little bit, but I mean, but that's a very context dependent example. I don't know if you've thought about that.
So I think I'm not sure if using late stage instance, are you talking about using late stage instance as the endpoint could lead to more overdiagnosis potentially? Or potentially.
Usually those early stage cancers where people worry about overdiagnosis, and diagnosing early stage cancer led some people to take really drastic action, you know, more than was warranted, right? So that drastic action is only warranted if indeed they're destined to progress in the late stage, but that's kind of the definition of overdiagnosis. They would have been okay had that early stage cancer never been diagnosed.
Yeah, but if they're diagnosed as early stage, that won't be counted as the benefit in terms of late stage reduction. That's my so if you're using this late stage reduction as the endpoint, so I think this when you design the study and when we do those calculations, the situation you're talking about is not part of this late stage reduction. But if we're looking at, like, say, how many cancers you identified, that will introduce more overdiagnosis potentially.
Could send a lot of people down a pathway of intervention that would, in fact, for some subset of them, prevent, you know, the late stage diagnosis, but potentially a lot more people are overdiagnosed and dealing with those harms of overdiagnosis.
Right. Yeah. That part we haven't looked at. Yeah, but looking at overdiagnosis, like how this screening program, like the harm in terms of overdiagnosis are, we also thought along those lines, but I think it's more complicated because we need to look at like competing risk events and those things we haven't thought it through, but yeah, but that's a very good point. Thank you. Okay, so now I'll move on to the second topic. It's the clinical trials augmented with the real world data. So this is like an overview of a more broadly the current practice that we see, at least from my experience, that we are moving towards more pragmatic trials that we're trying to save more, like regardless it's monetary saving or like save patients, save sites burden. So we're trying to be more practical. For example, we do less data collection, right? Like we don't force data collection at certain points, time points. So we're trying to streamline data collection. We're trying to broaden eligibility criteria that we don't put a lot of, exclusion so that we can enroll patients faster and try to reduce patients' burden. One important aspect is we're trying to leverage real world data more to augment the information we can get from the clinical trials. And for this work, it's motivated by a SWOG study that was done in mid-1990s, the prostate cancer prevention trials, PCPT. It was launched to examine whether finasteride can prevent the development of prostate cancer. And it's a prevention trial. Again, it's among healthier participants. And the follow-up of time of a clinical trial is typically limited, right? Like we have restricted limited resources. And for these trials, it only follows participants up to 7 years. And what about the treatment effects after 7 years? And for this trial, it's particularly interesting that it reduced cancer incidence, but the high-grade cancer incidence is increased in the treatment arm. So it was not proved in the end, but it actually invoked a lot of discussion, like why it increased high-grade cancer. And of course, with the longer follow-up would be part of it's part of the kind of research that we are trying to look, right? Like look at longer follow-up and see if that's indeed true after more years. So so for this along this line, investigators linked participants' Medicare claims data to their clinical trial records. And they use Social Security numbers, available Social Security numbers to link the trial participants to Medicare data. And it's still a randomized trial, right? So it preserves the benefit of randomization, but it can prolong the data follow-up. And with such linkage, we can identify more cases, more prostate cancer cases and more deaths from this prolonged follow-up in Medicare. And thus we can estimate the long-term effects of treatment. However, we can imagine there could be issues for this data linkage. It requires Social Security numbers, and that's voluntary. So we're not requiring everyone to provide. So of course, there could be like people not willing to provide social. And And it could also be incorrect linkage that due to mismatch. And for our case, since we are using Social Security, so for this work, we assume unique identifiers exist and incorrect linkage is not an issue. And many look at this incomplete linkage. And one thing is they don't share their social. And the other reason is if patients are not old enough to be incorporated in Medicare, we will not have that linkage, right? So Medicare starts from age 65. So this is a joint work with Gang, previous STAT students, and Yingqi, and also Zhao. So for our long-term effects definition, we use this Cox model to define the long-term effects. So if everyone from the trials are linked and we have the full data, we assume the hazard function has this following form, that beta 1 is the long-term effects. And we also consider a Cox model with change points. That's kind of motivated by the design of PCPT, which I'll touch base later. And we use Cox model as a working model because it's the most widely used model still. And if it is misspecified, the parameter of interest is still well defined. And of course, we also considered other possible extensions. Yeah. But that's the long-term effects we want to estimate. If everyone is linked, everyone are linked to a longer follow-up set, we can just run Cox regression. And for our case, not everyone is linked. So there could be multiple possibilities that depending on whether patient is censored in the trial and whether patient is linked to this Medicare set. And so we consider that just several notations. The T is the failure time, and C1 is the in-trial censoring time. And this Q is whether it's censored in the trial, and L is the linkage indicator. And based on these notations, we can categorize participants into different cases. The first one is patients who are linked and has an event in the trial. So T is observed in the trial. Okay, that's participants A, and he's in case 1. And the second is also case 1. Basically, case 1 are all the participants who are linked. But we can, again, among those who are linked, they could be either having an event in the trial already, or they don't have an event in the trial. They're censored in the trial, but then later on they're linked to the Medicare follow-up. So that's this L1, L equals to 1 and Q equals to 0 participants are those who would appreciate, because we would have not gained any information just from the trial, but with such follow-up, we get more information. And the second case is a participants who has an event in the trial, but who are not linked later on. And the third case are those who are censored in the trial and who don't get linked later on as well. And if we have such data, how can we do the analysis? We can do this complete case analysis. Just use case 1 who among those who are linked, we do the analysis. And we can also add this case 2 to the set of available data. Because for case 2, we also observe events, right? But actually such complete case analysis plus, it's actually biased because you include case 2 patients because they have an event in the trial. So now you're introducing bias because the participants will depend on how good they are, right? So so we propose multiple methods for such data structure. So first, we write down the likelihood, and we notice that the problem is case 3. We don't observe their censoring because they're censored and they're not linked in the end. So we do not observe T tilde and delta for them. So the first method is to just treat this case 3 as censored. And we call it non-linked as censored method. So basically we treat them as censored and fit Cox model. And such method should perform well when Cox model is correctly specified. And and censoring time is independent of T given X. And that's like kind of like a easy to implement, right? I just kind of code those case 3 as censored. And then but that requires your model is correctly specified. And then we consider this inverse probability of linkage weighting method, which depends on this conditional linking at random assumption. And such method is more robust to model misspecification. And the conditional linking at random assumption basically says for those who are censored in the trial, right? Q equals to 0, conditional on those who are censored in the trial, the linkage status is independent of the survival time given covariates. And this is related to missing at random assumption, but missing at random is imposed on the whole population. And for us, we're looking only at those who are censored. One good thing about this is for missing at random, we are looking at the whole population, including those who have an event, right, in the data. And for those who have event in the data, event in the data set, you actually can see all this. If you're looking at this linkage probability, you can actually calculate, and that might contradict the assumption, right? So, and for our case, it's testable whether such assumption is satisfied, and it's so it won't contradict the data. And given the conditional linking at random assumption, we can identify we can identify using the data, identify the quantity using the data, and basically it's inverse probability weighting type that for those who have Q equals to 1, just assign weight 1, and for those who are censored, we have this inverse linkage weighting, and yeah, and essentially we're using the this part trying to recover the case 3, right? So. And we also follow up with augmented inverse probability of linkage weighting method, and we derive the augmented IPW partial score, and that will depend on several outcome regression functions. It has a double robustness property when either linkage probability is correct, specified, or all the regression functions are correctly specified. But for this AIPLW method, since it requires a correct specification of all three regression functions. So it's actually quite challenging because of they're mutually dependent. And if we're just using parametric model to try to fit those functions, it may not be satisfied. So that's the challenging, and how to best implement this method is they were still kind of looking at. So for this study, there were almost 20,000 participants. And for our analysis, we exclude those who have a gap between the end of the trial and the start of Medicare claims. And those, as I said, like they may not reach the age of entering Medicare, so you would see the gap. And we have more than 16,000 participants, and the median follow-up is 16 years, much longer than 7 years in the original trial. And among the studies, we can see that more than 11,000 are linked to Medicare claims. That's more than 70%. They were more than 10,000 participants were censored during the trial, but later linked to Medicare. So this is really great, right? It provides much more information. And for more than 400 participants experienced the event during the trial, but not linked later on. That's case 2. And about 25%, 26% were censored during the trial and did not get linked later on. So we look at the outcome as the time to diagnosis of prostate cancer or death, whichever comes first. And we fit Cox model we for the outcome, and also model the linkage. And we consider a change point model because that's due to the trial design that at the end of the trial, all the participants who are not diagnosed with prostate cancer should go to do a biopsy. So there's like end of study biopsy. And at that time, a lot of cases were discovered. So we can see like a sudden increase in cancer incidence. So that's why we put 2 change points during that period. And we implement different multiple methods on the trials, and they are pretty consistent. And essentially, the finasteride, the longer, it's not significant. It covers 1, but before it's still being more protective in terms of the effects. And that's it for all of my talk. And thank you again. And if you have any questions, you can email me.
Yeah, I have some questions into.
Uh-huh.
So I think related to what Katie asked earlier, I guess there are a lot of people, if they do not develop late stage cancer in a control condition, the screening is not helpful for them. And so those are like large population where you have no effect of screening. So basically, the endpoint you use include everyone, which is good. Like, but is there approach, for example, you could consider those who would have late stage cancer in a control condition, and those are people who could potentially benefit from screening, and then consider treatment effect within that group. But I think it's challenging because it's a counterfactual or principal stratification type of subgroup for you to consider.
Right, but But are you looking at more like, say, higher risk group, or it's not just higher risk, but in that hypothetical world that they will, yeah. I feel that might be challenging to really identify that population in practice. And also, that of course would perhaps, you may observe a better effects, but just from the beginning, how would you identify that population? How would you implement that in practice might be challenging.
Yeah.
Right.
And I think it's probably challenging to identify, but ideally, we want to focus on a subgroup where the treatment effect is more apparent.
Right. So along that line, like for example, NLST, they're looking at the smokers. So trying to enrich the screening population first before even apply the screening test. So yeah, like say pancreatic cancer, the prevalence is extremely low among general population. So now they may look at different subpopulation that hopefully will make the screening program more cost effective. Yeah. Right. Thank you.
You mentioned like in the first project, you will integrate the sensitivity of the test into your calculation. I didn't see like.
Okay. Yeah, I think it's yeah, it's in here. It's hiding. Yeah, I didn't provide explicit form of how you calculate this green detected, because as the example I gave, like if at the time interval, we want to look at the probability of having cancer, right, in that interval. So that's either you do start to have cancer in that interval and you detect it by the test, and that's the sensitivity, how sensitivity come into play. Or you start to develop cancer prior to that interval, but the previous test did not discover that. So that's also related to sensitivity. That's a false negative. So you fail to identify that cancer and you wait until you're in the current time to find that. So that's, yeah, so it's hiding. Yeah, this. Yeah. Right. Yeah, and for this calculation, it does not involve specificity because it's, yeah.
See that it's only the probability of detection.
Yeah, detecting cancer.
From students.
Yes.
Curious regarding the first project with cancer screening.
Mhm.
I imagine that it's process screening or testing for other diseases, COVID or really anything else is similar.
Mhm.
Do you work with or draw from literature from testing or screening processes for other diseases?
No, we are mainly look at cancers, because if you have acute disease, it'll be it might be different. I don't dive into those literatures, but for cancer screening, perhaps it's more similar to sometimes like diabetes and those chronic disease, because the disease progression and the time, and yeah, that's more. Yeah, for COVID, like if you're detected, the development might be very fast, right? So I don't know like how team might yeah, because yeah, and it's also infectious disease, right? Yeah, it's perhaps quite different.
Yeah, I work on the HIV prevention setting where the one difference is there's no like early stage, late stage kind of distinction. It's mostly just detect like HIV seroconversion. That's what's most interest.
Right. Yeah, and also here they have this kind of disease state that you identify state and progressing to death, right? Perhaps not necessarily every disease will have such path from normal to preclinical clinical. So yes.
You may have already said this, but did you do any sort of, or I guess how sensitive were your results to different classifications of that early and late stages?
Yeah, that's a very good point. So essentially it's like how sensitive to like early stage sensitivity, like late stage sensitivity, right? Yeah, that's something like we would like kind of to investigate using our model to investigate and say how good your early stage sensitivity should be, right? And it will, of course, will vary for test, vary per test performance. We actually have the figure in our paper, like how it varies according to different sensitivities. Yeah, I didn't show here, but that's considered. Yeah, here we only look at how this power curve will progress per time. Yeah, in our paper, we look at more set of comparisons, including 3 annual tests versus 4 annual tests, and yeah, different test performance. Yeah.
Classification of like, I guess these are stages like stage 1, stage 2, and then late stages like 3 and 4. Yeah, did you ever try shuffling those around? Like early stage is just stage 1 and late stage is anything greater than that?
Yeah, so that'll reflect into how you the test performance, right? Like if you consider stage 1 as early stage, that'll affect your test performance, and also will accordingly affect all these parameters, like how long it'll stay in that early preclinical, and so all these are related, but typically for a particular cancer, it's well defined, like what are considered as early stage and late stage, and we can always do sensitivity analysis to look at different categories.
Thank you.
Thank you. Yes.
Thank you for your talk. It was very interesting. For the model of the transition, we use exponential distributions. Is this common for all the type of cancer, or are there cases where you use other distributions?
I think most of the time for designing purpose, we consider exponential. Yeah, I think it's like for studying design purpose, you don't want to get too complicated. And I think that's a very common practice. Yeah, but of course we could consider more complex model if necessary. Usually, I think especially for design, I think exponential are well accepted. Yeah.
Did you use binary endpoint or time to event endpoint? Because I guess it's a third time-consuming trial. There might be a lot of censoring and competing events.
Yeah. Yeah. So for our for study design, we only consider binary, but when we do analysis, we should consider time to event, I think. Yeah, to consider censoring, and yeah, for better, maybe for better power for data analysis. Yeah.
For the good talk and all the interactions and discussions, and let's thank Yingqi again for wonderful.
Thank you.